glasses.
No, I think they're very new. Very hard.
Yeah. Okay, it's 12 o'clock, guys. Okay, so what I'll do, I'll run around you all first, and then we'll take a conversation from there. We've got an hour, and I hope then we'll get some questions from our members. Okay. Okay, right, Jade, are we ready?
We're recording. It's turned 12 o'clock. Yeah, so I'm Jade Maloney, Operations Manager here at the Institute of Health and Social Care Management, and I'm thrilled to hand over the reins to Roy Lilley today as our chair of this event. So we're here for our Integrated Care Special Interest Group meeting, but in fact, it is a virtual wards roundtable, much anticipated by this group, and we hope you enjoy hearing from our panel today. I'll hand over the reins to Roy.
Jade, thank you very much, and good morning, everybody. Let's hope we can fill your lunchtime with all kinds of good things, nutrition for the brain box. We got three very interesting guests. I'm just going to run around them and let them introduce themselves. But virtual wards, of course, is something that we've had a huge interest at the Institute. In fact, we wrote a report on virtual wards, which I think is still on our resource site. And Jade, you can probably help people at the end to find where we'll find it. We'll publish a link, I think. And virtual wards, I mean, as far as I can figure out, there are now more than 340 virtual ward programs across England, and 58 of them opened in January. The interesting thing is, obviously they opened in a rush in January when there was pressure on beds, and whether or not you can do this kind of thing in a rush, well, I guess we'll find out. And it included a total of just over 7,500 beds. Now, the numbers have increased by almost 2/3 since last May, when we only had about just over 4,000. Jeremy Hunt said that it was the equivalent of opening 7 district general hospitals. What he omitted to point out was that to staff with nurses at 7 district general hospitals would require about 7,000 nurses, if you take into accounting staffing and shift work and training and days off and all the rest of it. But he's a politician, so we can't really expect very much. What I'd like to do is, Folarin, if I could start with you, please. If you just give us a little pen picture of what you're interested in this. Tell us about your company. We're not shy about having commercial associations here, so just tell us what you do, and then I'll come to Kris and Paul when you finish. So try and give yourself 3 or 4 minutes, and we're away. Yep.
Brilliant. Thank you very much for the introduction, Roy. My name is Folarin Majekodunmi. There's a doctor in front of my name because I have a PhD, but I'm not a medical doctor. My PhD is in medical devices, which of course are quite interesting in terms of any conversation around virtual wards. I am a director of what I think people call a boutique consultancy that works across health and social care called Peopletoo. We are quite small but very agile in our way of working, and have quite good coverage across the country working on these sorts of interventions, amongst others. My primary interest around virtual wards comes from working very much at the sort of front line of the integration agenda, primarily between health and social care, but also between in and out of hospital services. And obviously there's a really important role for virtual wards to play within a wider ecosystem of integrated services. And I've been fortunate to not only evaluate a number of virtual ward services, but also to set up 1 or 2. But as I think I said to Roy before we actually started the call, the virtual wards that I've set up haven't been along that sort of hospital at home model, but more around the sort of Croydon model of admission avoidance, and also preventing primarily avoidable non-elective admissions for individuals who are aged over 65 plus with 1 or more long-term condition. But at the same time, in all the work that I've done, in all the guidance that I've read, and the practical examples I've had of these things working, I think there is quite a lot of promise for them, and therefore really interested and really excited to be part of this auspicious roundtable. Thank you very much.
Thank you for that. I'll come to Kris and Paul in a second. Just to pick up on a couple of points that you raised. Just maybe we can discuss them in more detail later. I mean, hospital at home, that's been going around for ages. The original hospital at home was called a GP, and he used to pop in and see how his patients were, but we don't seem to do that much anymore. I'm probably defaming all the GPs and their right to me, but I mean, it's very difficult for them to do it now. Did you find that with the hospital at home systems, that the secondary systems were ready for what happens when there was an inevitable depreciation? Because most of these issues revolve around geriatricians, geriatrics, elder people, frailer people, because they are the ones that we find difficult to move through the systems because of the problems in social care. So what did you learn from of the readiness, really, or how to make ready the secondary care when the hospital at home system was no longer appropriate?
Yeah, that's a really good point. And I think on that point, I would make sort of two general observations. The first is, I'm not sure, and I'm sure that Kris will come on to this, I'm not sure that technologically in previous years we were at the level of being able to get the full value, the full potential of hospital at home type services which we're getting now. And I think as a consequence that drove a lot of risk aversion in some of the behaviours of the physicians themselves. I think what's quite interesting is with COVID and the crisis it created has created an understanding of the ability to leverage technology to enable greater care delivery within home settings. And I think some of those behaviours within those physicians are beginning to change, and their risk appetite is beginning to become better aligned.
Sorry, just to cut across you, yeah. Is it about training, do you think, or what you're talking about is experience? If we're going to roll the experience forward, it becomes training, doesn't it?
Yeah, to a certain extent, I think it is. I mean, there are wider conversations around decision making for physicians in general. And
I think somebody's got their microphone on.
I'm in a meeting. Oh, okay.
We know you're in a meeting, darling. We can hear you. Yes. Just battle on. Oh, hang on. Now we've lost. Okay. That's right. Don't touch. That's it. You're back with us. Okay. Don't touch anything. Jade will do it all. Don't worry. Yeah.
So we're saying I was fortunate to be part of NHS England's Getting It Right First Time programme, GIRFT, and I won't go into that in too much detail.
But it's a fantastic programme.
It is indeed, and Professor Briggs, an amazing and inspirational leader. One of the interesting things about GIRFT was it really showed that actually physicians sometimes have make decisions that aren't driven by best practice or generally accepted, what is generally accepted to be good practice or generally accepted, shall we say. And some of that is to do with their own independent responsibility for the welfare of the patient. And therefore, to your point about taking experience forward becomes training, I think to a certain extent there is some of that. But I think some of it is also is that they need to see the proof of the pudding themselves. They need to see patients who are thriving within those environments.
It's their risk, isn't it? At the end of the day, you know, if something goes wrong, it's their registration with the GMC that's up for. Yeah. Right, Kris. Let's move to you now. Just give us a pen picture of your involvement with this, and pick up any of the threads from Folarin, please.
Yeah, brilliant. Thanks, Roy. So my name's Kris Glover. I run Neon Health Solutions. And we really support change management programs with technology, and we integrate data and information to support that change management process. And I'm really interested in sort of how these programs move from being sort of best practice and these pockets of best practice that we have, and how we can understand what makes best practice really sort of work, whether it's a leadership element, whether it's a technology element, or whether it's, you know, the way that sort of partners are integrating across the piece. And it strikes me that the virtual ward systems can be a real sort of lever for moving us towards the, you know, better integration across organisations, because they're really sort of practical ways to engage partners across different organisations. You spoke before, Roy, about that question of what happens when patients then need to come into hospitals, when they can no longer sort of manage in the system that at home. And I think that's the big challenge, isn't it? What happens when things don't go as we'd like them to? What happens when we need to move to the sort of next level?
Kris, that's the point, isn't it, really? I mean, and what came out of the virtual wards report that the IHM did, I think it was last year. And again, just to remind people that Jade will put a link up for us so we can all download. It's only 2 or 3 pages, and it's a summary of a round table. What was clear was there were examples of people who did it very well, but the certainly as far as the virtual ward was concerned, there was a worry that, okay, it's 4 o'clock on a Friday afternoon. Mrs. Brown has had her kit and fiddled around with it and sort of got herself straight, but actually is her stats are down. She's not looking well at all. Now, do we admit her, or do we just get someone to pop round and see how she's doing? We might be able to avoid an admission. Who does that? Well, you bring up the community nurses who by then on a Friday afternoon, you'll be speaking to an answer phone because they'll all be rushing around trying to sort out their stuff for the weekend. And the last thing they want is some wacky techno policy in secondary care to suddenly dump a whole load of customers on them because they haven't got the people to do it either. So that came out quite clearly as one of the sort of, well, I won't call it a flaw. Let's find a better word. Maybe we'll go to the lawyers who've always got a better word. There's a lacuna, a hole in the policy.
And isn't that all about people and sort of connections between people in different teams? If we look at mental health, which has been doing this for a long time around, sort of home-based treatment teams, they have crisis teams, and they have inpatient teams. And those teams are really effective when the leadership across the 3 different sort of teams know each other, work well together, and can do those, can sort of make those decisions and sort of pass patients around those interfaces without too much friction, so that they know what the sort of admitting criteria are. They know that, and from the acute wards perspective, they know that when they get those referrals on a Friday night, they know it's genuine and they trust it, and that takes time to build up.
But Kris, we still have to resource that, don't we? Because
of course,
if somebody was in hospital and they had a funny 5 minutes, well, they're in hospital and it doesn't really matter. I mean, it matters to them, but from the operational point of view, it doesn't matter because that's what hospitals are for. But if you've got somebody who's likely to be stranded for the weekend where primary care is not going to be able to respond, you're left with dialing 999. This then will be a category 2 call or even category 3, really. And you could have someone unattended for hours. I'm just saying, asking for a friend. So I mean, how do you? I mean, I know you work across horizontally across the system. I mean, how do you avoid that?
And I think that's the question, isn't it? And it's how do we look across systems that are working, that are in place, that are working well, and pull out all of the features of those successful programs, and how do we sort of boil that down into a recipe for moving this across organizations? Because that strikes me as something that the NHS has millions of pockets of best practice, and whatever it is, there's pockets of best practice. But taking that best practice and delivering that as business as usual across the system, that's the challenge, isn't it?
It's very difficult. I mean, GIRFT is, I think, one of the best things the NHS has got. Unfortunately, it's under-resourced, it's had budget cuts, it should be doing much more. But of course we have, and we started the Academy of Fabulous Staff, which is the only repository of best practice in the NHS. It's the only, we run it, it's free. We get 6,000 hits on the website every day, people looking for solutions, and I'm very happy to do it and we fund it, but it really shouldn't be down to us. Let's move on to Paul. Paul, good morning, good afternoon, rather. It's nice to see you. Paul, of course, is a fabulous artist, much better than I am. He's a proper artist. He's had training. Somebody showed him how to work a pencil sharpener, but so he's a great artist. But never mind. Talk to us about how you come to this, Paul.
Yeah, well, I'm Paul Rylance. I'm CTO at JKMCare, and our focus is the sort of non-clinical aspects of care, including virtual wards. So it's the operational logistics coordination, and it's across NHS, adult social care in local authorities, and care providers, and how that sort of happens across the virtual ward environment is a very, very interesting mix, and we try to elevate it beyond the local level, but also right up to the regional ICS, so they've got real-time visibility of exactly what's going on in their catchment area.
So fundamentally, just so you can take the data. Yeah, are we talking data here?
Well, yeah, from a virtual wards perspective, a lot of the data is clinical monitoring, as Kris and I'm sorry, Folarin have already alluded to. So, and that's the clinical focus. We're focused more on, well, where is the patient, and if they're in a virtual ward, could we transition that patient back into hospital and have audit trail of that transition? And how will they get there? Is it ambulance? Is it just normal NETs, non-emergency type transport? And how does it all string together so that when people in the higher levels of ICS start asking the questions, we've got all that sort of logistical coordination data for them to pool on and identify where the real problems are occurring, not from a purely clinical data-driven.
Right, so that's very important, isn't it? Because this is what I'm always banging on about inspection. It's a waste of time. We should be taking the data and finding out what's going to happen rather than turning up and finding out something's wrong too late. So from your excuse me, from your experience, Paul, what are the top line bits of learning that you've accumulated so far when you dig into the compost heap of data that you've got?
Yeah, well, there's a lot of I'll say individuals and organisations that are trying to be too risk averse, or they're trying to switch the focus from where the real problem is because it may be down to them. They're trying to push that spotlight to somewhere else. And the data won't lie. The data will actually tell you where the real problems are. So there's a little bit of reluctance, I guess, there. But I think this is all very new. There's been a load of people saying that NHS as a body isn't great at doing the operational aspects and the coordination side of things. So this is all very new to them, and some are struggling to grasp the sort of opportunity that's there.
They were kind of shoved into it, weren't they, really, with COVID? They didn't have much option. I mean, if we asked ourselves, why are we doing this?
Yeah.
What are we doing? Well, we're doing this because we ran out of beds.
Yeah, I think that is so true, but it's also possibly one of the wrong reasons to be doing it. If you want people to go into virtual wards, they have to meet a certain set of criteria to be able to benefit from going to a virtual ward, i.e. home. Yeah. If you're doing it just to free up beds, there's a propensity there or an urge to start dropping that criteria just to meet the bed volumes, where that's really the wrong sort of focus, if I can be so bold.
Yeah, Folarin, you're nodding away there. You've seen that, I guess.
I think I've seen something very similar manifested, and this is quite a controversial thing to say, but there was a suggestion during COVID, and it's not quite to Paul's point, but somewhat similar, that the definition of whether patients were medically fit or medically optimized and safe to be discharged seemed to change as would best respond to capacity issues. So we have seen something we have practical evidence that something very similar has happened, and inevitably I'm sure the evidence will come that something similar is happening with the virtual wards as well.
That's very sorry, just a second, I'll come back to you, Paul. That's a very important point to say, because the distillation of what you've just said is the question is someone fit for discharge, is the sum total of the number of beds.
Yeah.
Paul?
Yeah, and that's exactly where the management mindset is, and the clinical mindset may not align to it. And I think earlier examples of D2A, where D2A had a fantastic criteria set over a decade ago, and it worked really, really well across London. But then when COVID struck, that criteria started to be eroded very quickly and literally opened the floodgates for hospitals to discharge people as fast as humanly possible. Now, that's not a criticism, that's just an observation of what went on.
Yeah. Well, Kris, yeah.
Within all of this, how do we manage the difference between sort of the risk of the patient being at home and quality of life of patients as well? Because many patients don't want to be in hospital, do they? They want to be at home, even if they're slightly more risky at home, even if they're, you know, they've got sort of all those factors that mean that they may get.
Kris, can we? Sorry, it's a slight delay. I didn't mean to. Well, I did want to cut into what you're saying. I mean, are we in danger here of making some assumptions? I mean, if I, you know, if I was a little old geezer and, you know, I wasn't very well and, you know, some nice lady turned up with an iPad and a thing to put on my finger. Actually, do you know what? I'd feel safer in hospital. I really would. All this business about, well, people would prefer to be at home. Is that universally true? It's become a trope, I think. But is it universally true that people want to be in their own homes? They want to be where they feel safe, I think. And okay, so talk to me about the difference between those two things.
So of course it's not universally true. I think, you know, different people have different views, but certainly from my experience, when my dad was on the end of life pathway, trying to get him home to finish off that pathway was just nigh on impossible, because the clinicians we were talking to had a process and a structure and a way they wanted to sort of manage my father, and they were talking about the risk of him dying at home being greater than the risk of dying in hospital. It's like, well, he will die. That's just a fact of life. But you know, the reality was that there wasn't an option, there wasn't a choice. There was, you know, there was just one sort of approach.
And there's no doubt about it. End of life care, bereavement management, all of that is a whole separate piece. And we've got a publication on that as well, which Jade will no doubt be able to find for us, and people can download what's in that. And you are right. But if we just park that for a moment as a kind of discrete the patient and family experience, if we look at someone who is, I mean, look, I don't know, like a UTI or something, you know, which often ends up with somebody being giddy, falling over and breaking their leg or something. But I mean, I'm just wondering whether maybe we're spending too much time on it, but I'm just wondering whether it is universally true that older, frail people who depend on carers, domiciliary services coming in 2 or 3 times a day, whether they do actually feel they want to be at home, or whether they would like the enveloping care of a hospital. Somebody, yeah, please come in.
So just to come in on that, I mean, you raise a really good point, Roy. I think the bit of evidence that I have that I think is best aligned to a response to this is just looking at the rates at which generally older individuals, some who go in with a UTI, as you say, they have a fall, the rates at which they become deconditioned, the rates at which they lose their independence and become highly dependent on institutionalized care. I do think there is the one key thing that it does enable is of someone being in their own home is that they're in situ, they're within their own natural environment, and they are having to manage themselves within that environment. And I think that emboldens them and empowers them, that when they come out,
that's a really good point.
To be able to stay within that environment. Because, you know, rather like Kris, my mother was very, and she passed away recently. And I recall my father wanting to call an ambulance for her and saying, you know, don't call an ambulance under any circumstances, because they will take her into hospital, and despite their best efforts, they will kill her. And that's what I meant. And that is the reality for a lot of older people, unfortunately.
I think that there is the deconditioning argument is very good. I think it's a 1% a day, isn't it? For the over 70s, they decondition 1% a day. You're nodding wisely there. You're the data.
Well,
get the numbers right.
Yeah, well, I'm thinking of the opposite end of the equation as well. You know, the deconditioning, absolutely, but you've got the element of delayed transfers of care, which is a very complex problem and a very long-standing problem. And now you've got the virtual wards, which by proxy presents an opportunity to diffuse delayed transfers of care by getting other patients out. Now, you don't want them to deteriorate in hospital, but you don't want to discharge them, let's say, potentially inappropriately or too soon, because it suits the environment in which you're working or the pressure that you're working under. Does that make sense?
Yes, but I mean Amanda Randall and Amelia Randall. Sorry, Amelia. Amelia Randall has just popped up with a question. And good afternoon, and thanks for joining us. She says, "How do we work together to support patients to feel safe when cared for at home?" Question mark. Well, it's a very big question mark, and of course the difficulty is, Amelia, we probably don't, do we? I mean, we get in different levels of domiciliary care provided by people who are probably some of the most poorly trained and poorly paid people in the whole landscape of healthcare, looking after some of the most vulnerable people in the landscape of healthcare. So I think, and if you guys want to comment on it, Kris, you've got a view on that. I mean, I think Amelia has asked us a really difficult question there, and the answer is not probably the answer she wants.
Yeah, of course, and I think as you say, we're talking about that level of carers who are at the sort of least well trained, and when we look at these kind of home visits, it's not just about the numbers. It's not just about blood pressure and pulse oximeters and all those things, but it's also about how the patient is looking after themselves, whether they are washing properly, and all of those other sort of indeterminate things that good systems will pick up on and will be able to act on. So it's not just about having people come into patients' houses and take those numbers or make sure they're taking the meds. It goes beyond that.
Yes, and Kris, Ben Panton, he's saying he doesn't sound very patient-centered pathway, Kris. And I think probably you can answer him. You can answer Ben yourself, Kris. You're a big boy. But I mean, my intermediate view of that is he's often not a very patient-centered pathway.
And and that comes down to choice, doesn't it? But until we can get effective systems that offer that choice, then that choice will never truly be there. Do we give patients the choice of being in hospital or being at home?
Okay, let me come at you again on the choice thing, and I don't know, Paul, if you've got any data on this, and Folarin, you will probably have a view on it. I mean, when I don't get this choice thing. I really don't, because I mean, I don't know what to choose. And I'm an informed patient, as you could probably have. I'm a nightmare patient, probably. But I don't know really what my choices are. If I wasn't very well and I live on my own and I think, well, do you want to be here and we'll support you with an iPad and bits and pieces, or do you want to be in hospital? I think, do you know what? I think I'd probably rather be in hospital. But I don't know, I know I'm going to decondition at 1% a day, and I just hope I'm not going to be there for more than 30 days, because after that, it gets very difficult. I mean, I'm not sure where choice fits into this. Is it okay for us to impose a choice knowing it is the best option, or should always the best option defer to the uninformed choice of the individual?
You're asking an impossible question there, Roy, because you're dipping a toe into deprivation of liberty. And you're dipping a toe into, well, who's the best person to make that choice? Is it the clinician? And you could argue, well, if they're too risk averse, no, it's not. And then is it the patient? Well, how informed are the patient? The fact that they want to go home, would it be suitable for them to go home? Now, when we come into end of life and all that,
don't
exactly. So
we'll do another.
So that choice argument
is I mean, this whole thing about informed choice. You know, if we were informed, we wouldn't have to make a choice. We're making a choice in the dark. That's what I don't know. Am I right? I'm a Folarin. You will now pronounce wit and wisdom on this topic. And
yeah, I think you make a very good point, and I think and I can see both sides of the debate. I think what I've been coming back to whilst listening to the discussion is that there are areas actually where these things work pretty well. Actually, they probably don't get the sort of airplay that they need, and perhaps aren't held up as exemplars the way they should be. But in a number of areas, in a number of places, ICBs, there are overlapping services that mean that individuals who are within a home setting can be assured that they can be maintained there safely, and if needed, they can have their, be escalated up to readmission into the hospital. So not only do you have things like domiciliary care and you have telecare, telemonitoring, those sorts of things, but you also have urgent care response services in case they dip into crisis. You have home visiting teams that are delivered by things like integrated neighbourhood teams. You have a really active and engaged third sector that coordinates with all the other system partners to make sure that those individuals within that home setting can be maintained there appropriately. And I think it's at that point in time that the choice becomes informed. When you know what you're dealing with and you know the difference between staying at home and staying in hospital in a material way, then that becomes an informed choice. But currently, I think across much of the NHS and health and social care in general, what patients see is a very disjointed system where the only surety and comfort that they feel they can get is being institutionalised, even though, as you pointed out, Roy, that leads to deconditioning and a longer term loss of independence. So the choice element just to give them a real choice. It can't be
to add to that point, Fran, because you'll want to comment on this. Fran Hussein, and hello, Fran. Thanks for joining us. She says it's not just being well informed, experience also matters, which is, I think, was your point, which is why I interrupted you. Experience also matters. Anyone having spent 2 long hospital stays will have a different position, and that's very true, isn't it?
Yeah, that's definitely very true. And recently did some analysis, and which was really quite shocking. When you look at the number of people who go into hospital, who go in with 0 procedure, who go in with an ambulatory care sensitive condition, which means they don't need to be in hospital anyway, and then look at the number of those who've gone in more than 3 times a year and stayed for more than 10 days. It's an incredibly shocking number.
Yeah.
And that then speaks to all the issues around capacity and all those sorts of things. So not only are we reducing our effective capacity, we're also taking people into hospital who don't need to be there.
That's a very good point. I've lost Kris on my screen.
Yes, I think he's dropped out for some reason.
We lost
Kris. That is a really good point, Roy, because it again just starts to shine a spotlight onto the subtle shift from delayed transfers of care to length of stay. Now, there's some very foggy areas there. So if somebody, let's say, focuses on people who have had a length of stay of more than 14 days, that's all well and good. But what about the ones that have only been in a length of stay for 7 days, but that length of stay was 4 days of delay because of an external influence? I'll give you an example. Doris gets admitted to AMU for 3 days observations, and unfortunately her house gets broken into and the door has to be replaced, and therefore she stays as a patient 4 days longer than necessary while somebody fits a new door.
Yeah.
But it won't be recorded. It won't be shown on anybody's radar, and yet AMU are going to suffer enormously through their capacity management.
That's It's a good point. Jade, have we lost Kris?
We have. I'm just trying to get a phone number to see if he's okay to rejoin.
Yeah. Okay. Well, we'll bash on. We need to get him back. Thanks. I'll leave that with you, Jade. Okay. So we've had a sort of good run round of the problems and the issues and the, and I think it is important to look at that. And there's another issue, Folarin, when you were talking, it made me think about the ambulance service as well, because I forget which ambulance service it was, but there is one that did a really good job with virtual wards. They trained their paramedics when they responded to a virtual ward response. As I say, it was category 2 or something, but their prime objective was to try and see what they had to do to maintain that person in the virtual ward rather than just scoop and run. I mean, it took a big chunk out of the running time of the ambulances because they were delayed, outside Mrs. Brown's house. But the interconnectivity of the response was really important, I think. Anyway, I'll come to you, Paul. I mean, you've got the data. Can you move us into what good looks like?
Well, yeah, and I guess as a heading, it would be broader visibility. Historically, NHS have looked at NHS data and predominantly clinical data, and social care have done the same, and care providers are even more siloed. So, if with the advent of ICSs, ICBs, if we had that broader visibility that provided them with the data to say, well, let's not play each silo off against each other, but actually see what good looks like. So if there are delayed transfers of care in a hospital, that's also going to impact discharge teams in local authorities. So let's attack that rather than trying to obfuscate it and just get people out into virtual wards. So what good looks like is that overall visibility in real time, so that you've got both the tactical choices and the strategic choices in front of you.
And visibility adds up to nimbleness, doesn't it? Agility, yeah. So what good looks like is the ability to move quickly when situations change, and you can do that really by boots on the ground. And the whole idea of this is that we haven't got enough boots on the ground. People in bed that you can see what's happening, or the data.
Yeah, I think your Power Hour last year, Roy, brought all this to the surface, didn't it? Rather well. And Alison Leary made the valid point that nursing isn't just about tasks. It's about all those trained observations that you do that you can't do in virtual wards that suddenly go missing. And the anxiety that causes the professional of not being able to see the person and pick up on that nuance.
Oh, here he is. Kris is back. Welcome back, Kris. He's still getting himself sorted out. Okay, and so again, just to kind of dig into that answer a bit more, we might conclude from that the virtual ward is not a step down from secondary care, but it might be a step up from primary care.
That's a really interesting perspective, and it's almost, rather than a step up or step down, it's a step to the left or right, isn't it?
Yeah,
because they're still part of the acute environment.
Yeah, we're into Strictly Come Dancing here, but yeah, doing the chassis turn. But you're right. I mean, maybe when we look at this, we're looking at this as, oh, you can't go to hospital, so use your own bed and we'll send the hospital to you. Actually, it's not really, is it? It's somebody's poorly. The GP can't do it because we're losing 500 GPs a year. So who's going to do it? So it's something else, isn't it? It's not primary care, secondary care. It's blur care. Whatever.
It's an additional conduit to ease pressure.
Yeah. Well, let's just dump that on Kris then to punish him from running away when he did. Have you picked up enough of that to make a response, or do you want to?
I have, and I mean, it's a really good question. I think one of the things for that sort of sidestep from primary care that strikes me is around conditions and focusing this on specific pathways. So one of the really successful things around the GIRF programme has, in my mind, has been that they've really focused relentlessly on individual pathways and built programmes and structures and models around those pathways. And it strikes me that doing that same approach for this kind of thing really sort of adds value, because then we can take those COPD patients, we can take the specifics, and we can build a process and a pathway for it, so that we can understand the data, we can understand the process, we can understand the risk management, we can understand what happens when patients sort of need to vary from the place they're in to a different care pathway and so on.
Yeah, and your frustration was before we somehow managed to press delete, was the ability or the inability of the NHS to share best practice. I mean, the extent. I mean, I'm a big fan of the GIRF program, but I'm not sure it gets the traction that it needs.
But it's been much more successful, I would argue, than practically any other change management process. And I wonder whether that's because it is so focused on specific sort of practical pieces of work, rather than sort of trying to focus on everything. You know, it started obviously with orthopedics, but it started with knee replacements, with hip replacements. It
went where the money was. I mean, 23% of knees have to be done again.
Yeah,
and that's a lot of money, and it's a lot of pain and suffering for the individuals. Why? Is it because it's a very difficult joint? It's held together by elastic. It's not, you know, it's hard to do. I think 9% of hips have to be done again. That's a shed load of money when you think of the number of hips that we're doing. So they followed the money, didn't they?
Yeah. And the same, you know, could be done in, you know, for virtual wards, couldn't it?
Well, certainly with this. Let me just, I'm just going to pause you there, if I may. I just want to bring in Jerry Burke. Good afternoon, Jerry. Thanks for joining us. And they say, do Jerry with a G. That's a lady, isn't it? Is that, or is it Jerry with a G that's a man? I don't know.
You can have both, I think.
It was a man. Okay, Jerry with the G's. And what it can, you can get Jerry as a lady or a man. So forgive me if I've said the wrong thing there. But Jerry says, do pathways not reduce flexibility in the system? Now, the answer to that is probably. And the next question is, does it matter? Kris.
So I've got an engineering background, so I would sort of argue for you know, that consistency, but consistency in the right way, because, you know, flexibility. When we talk about flexibility, and particularly when we talk about flexibility within clinical pathways, is that a good thing? That we've got different clinicians who have got different perspectives and different sort of backgrounds, and they come from different places, making different decisions whilst looking at the same patients. Now, that's not a great place for us to be, surely. So understanding what those differences are, understanding why those differences are being applied, and then trying to sort of distill that down into what is genuinely best practice, and then repeating that best practice. Yeah. Now, that best practice may change over time. It almost certainly will change over time as we understand more, as we learn more. But surely there should be one sort of version of the truth, one best practice.
That's a really important point. Folarin, what do you think? I'm sorry, you were trying to get in there and I cut you off.
No, I think Kris has made a really good point. I think pathways are incredibly, I mean, they can be quite restrictive, but I think that a lot of pathways that we have, one can be assured there's a lot of volume, there are a lot of patients' experience along those pathways that is somewhat similar, and therefore actually looking to standardise them is a good way of reducing variation, improving the outcomes that are delivered. I think going to something that Paul said earlier on, the main issue that we have is that where you have different owners of the different elements of the pathways, that's currently where we have this problem with interoperability. So my version of the truth is based on my delivery of the pathway, and if I'm someone from social care, that's only what my system's shown me. I don't know what's happening within an NHS setting. I don't know what's happening within a primary care setting. I don't know what's happening with a secondary care setting, and that's one of the reasons I think why care can be quite disjointed, and keeping people within that home setting can be quite difficult to do because we don't have a full picture of their experience, nor what the best possible intervention is for them.
Yeah. And, you know, dare I say this, but I mean, so much of commissioning and what have you is done by, you know, middle class young people, you know, and they live in very different conditions and lives to the people they're commissioning services for. I mean, I always say you shouldn't commission services for the elderly all the time. You can still cut your own toenails, because that's the first thing that goes. And after that, all commissioning should be left to me or somebody over 70, I think. And I can still cut my own toenails, but I mean, it is a real problem. Okay, Kris, what we're trying to do is we've got a quarter hour left. Just let me touch on this. Fran Hoosen again, she's come. Thanks, Fran. She says, what about preparing patients about the benefits at home care? To use a general term, in terms of home organisation and preparedness, such as keeping medicines safe and secure, good housekeeping, about wearables and devices such as blood pressure monitors, oximeters, and home self-testing, antibacterial products. It will take some time for people to fully accept virtual care. Perhaps third sector organisations and the ICS could start on the preparedness route. It's a really good point, and if you'll forgive me, Fran, I'm not going to put that to the panel, because that looks to me like it's a whole subject for another lunch hour, and we'll make a note of that, Jade, perhaps, and think about having a panel on that. But it's worth looking at. There's the Dutch. What's the Dutch healthcare at home? Bergzorg. Bergzorg, that's it. Bergzorg, yeah. It's worth having a look at Bergzorg in Holland, Fran, because that's exactly what they do. They've got fantastic home care system working there. So have a look at that. So coming back to the matter at hand, but I asked Paul what good looked like, Kris, just so you know, and he said he thought good looked like visibility, so that people knew what was going on and we could be nimble in our response and prompt in our response. It still leaves the question, I think, Paul, who is going to respond? Because the connection to other services is still a service interface, and when you get an interface, you get a failure.
I totally agree with you, Roy. And just to pick up on Chris's point, I'm an engineer background as well, and I totally align with what he's saying about, yes, there may be a lots of nuance in pathways, but if we have an established pathway, and that pathway is along the patient journey, not silo-centric, so the pathway extends all the way from when the patient leaves home to when they get back home or a care home or wherever they're going.
Yeah.
Then we have visibility of that. And then we can say, well, what would happen to that overall pathway if we did this at that point? And you'd be able to see it in real time.
Right. Listen, I've got to read this to you, Paul, because this is from David Trigger. And good afternoon, Dave. And it's great to hear from you. I know you've had some difficulties at home. In fact, he tells us, my partner is presently in a virtual ward following her second fall. Now, here's the issue, and this is I'm going to ask you all three, but I'm going to come back to you, Paul, here. I'm going to nail this on you. Our problem is not having treatment, but the number of organisations involved. Lots of folk in the orchestra of health, but there is no conductor. There is no coordination of care. Yeah. So I'll let you off with a nod and an agreement. Yeah. Okay, Kris. Just hold fire. I'm coming to Folarin now, because there were a couple of issues there. I mean, so if you just sort of brush against Dave's observation about there being no orchestra, no conductor, and give us your view of what good looks like.
Yeah, so it's a really good point. And sorry, I'd already started to write a response before you read it out, Roy. Ultimately, and this is a really unpopular view, I hope I don't get into trouble with it, ultimately it should be the responsibility of the GP as the family doctor, as a first.
Whoa!
Oh dear. Okay, should I stop there?
Don't do that to me. I get the letters. They'll write to me.
But there are other, I mean, in a number of health systems, you're probably aware that they have sort of care navigators who help individuals, ensuring they're making sure they access the right services at the right time, providing not just advice but some form of care as well at a very sort of basic level, But as I said, and again,
so people know, we're going to train 6,500 care navigators. Apparently, they're going to be based in primary care. They're receptionists by any other name, and they're going to try and point you in the right direction. They are not a registered body of people. They're bound to confidentiality by confidentiality contracts with the GP. There's a question over confidentiality, and there is a question over liability if they get it wrong. Who carries the liability? Is it the GP practice, or do they have an individual responsibility? So it's not quite as easy as that. However, back to you.
Sorry to interrupt, but it's a pity because that's a bit of a dilution. There were care navigator roles that existed a couple of years ago that required there was a postgraduate diploma in that I think resulted in a higher level of skill than what's currently being proposed, and it's a bit of a pity because again we're calling two quite different things the same thing, and therefore misaligning expectations, shall we say.
That's a very polite way of putting it. Right, now I'm not going to let you off the second part of the question. What does, from your experience and the work you do, your products and services, what does good look like?
So what good looks like actually is, and there's a really good, some really good stuff that's being done around this in Suffolk and North East Essex ICB, is what they call integrated neighbourhood teams. And again, this nomenclature issue, they're not quite what's come through from the Fuller report, but essentially there are local teams working on a locality basis that involve a community nurse, an OT and a social worker, all working together to support those patients who are the most vulnerable in their intersection with services across health and social care. So there's some really, really good stuff coming out of that. And those teams are also starting to use public health data to enable them to proactively support individuals with preventative measures. So there are things out there. It's just really real pity that actually that some of this isn't more widespread in how it's being delivered.
I mean, they are the three musketeers of this, aren't they? A nurse, an OT, and a social worker. That's probably what you want. I think there's another something else is going on down in Bristol as well, where the OT and a paramedic are doing category 3 calls. And doing them very successfully. And my memory serves me, last year they saved 580 odd admissions, which is a hell of a lot of admissions, just by simply turning up and doing whatever was required there and then. So the OT turned up with an electric drill and put the handy bars up in the bathroom and all that, which was brilliant, really. And you know,
those things sort of sink or fail based on the individuals, don't they?
You're absolutely right, Chris. I mean, but so much change is personality led. I mean, one of the things about being a change maker is around personality. Right, Chris, if I give you 3 or 4 minutes just for you to sum us on what you think good looks like from your point of view, your products, your experiences, your clients.
I think it always comes down to integration for me, and it's the integration between the technology, the people, and the systems to make this work. And you know, there's no one thing that is going to make this work. It will be different in local areas because they'll have different systems. But it's not just about, we've had some messages in the chat, it's not just about health, is it? It's social care is as much a part of this as anything else. It's about sort of enabling people to manage themselves, to look after themselves, and to give them the support that they need to be able to do that, with some sort of guide rails to ensure that when things don't go quite right, that we can sort of pick them up and move them into, you know, different care setting to sort of manage that.
Yes, and Kelly Gadis, Kelly, good afternoon. She says social workers don't deliver care, they assess, refer, commission, and direct care provider do the hands-on job. Well, I mean, I think we can all see that, but the interface is really quite important there. Integration, just quickly, Paul, if you would, because we're running up against the buffers of time now. Integration, I mean, we've got, if we're looking at, you know, the data that you pull and the systems and so on, we'll have, we'll probably have system 1 in the GP surgery, we'll have Epic in the hospital, we'll have some other system in social care. You know, we've got loads of providers here. It looks to me like, you know, integrated integrating data and whatever is completely beyond the NHS. Now we're moving towards things normalisation of care, isn't it? Where we just extract the bits we want and put it in another repository. I mean, to what extent is this interoperability? I mean, it's being totally beyond the NHS to manage. But I mean, have we moved beyond interoperability now? Are the systems smarter that we don't need that interface, or are we saying that we still need it? Is it a barrier?
I think it's going to be a transition, and I'll be succinct. A lot of the historical incumbent systems do not have the design capability to cater for what's being asked of them. So simply integrating a system that will only give you limited data is not going to give you an advantage. What needs to happen is, during that transition, is for other systems to be able to say, well, we can provide the data that these systems can't. And people like Varroa, who are bringing all that data together, that's where they should be looking. If you just rely upon the incumbent systems, you will have more holes than fabric. Yeah.
You're nodding away there, Folarin. Do you see that in your approaches?
Oh, hugely. There's a huge issue around it. I always describe it to clients as being a bit of a Tower of Babel situation. It doesn't seem like we can get people speaking the right language from a sort of interoperability perspective. And I think the danger is, and I know this from the conversations I've had with some of the providers of those systems, is, I think as Paul said, is that I'm not sure that they are incentivized to provide a solution. I think we need to find something that sits above them, because I remember the digital roadmap and the digital exemplars, etc., from years ago, and it just feels like very, very little actual progress has been made.
It hasn't. It really hasn't. I agree. I mean, the answer is in procurement. Don't buy anything that can't speak to everything else. It's simple enough, but they pussyfoot around it. They won't do it. And so I don't know. Okay, well, look, we're nearly there. I've just got one more question for you. I think I'll come to you first, Kris, if I may. Virtual wards, is it a fad, or will it fizzle out when we have enough nurses and enough beds?
I think it's got to be long term, isn't it? I think it's a real sort of shot in the arm for wider integration, because it does give focus to bringing those different organisations and different teams together to make a real difference for patients, but also a real difference for, financially to sort of pull care away from acute settings.
Yeah, so you see it as not only has it made a change, but it is a change maker.
Absolutely.
Yeah.
I think it's a catalyst for sort of spreading that integration further.
Yeah. Paul, what do you think?
I think it could be a catalyst, provided that it's used for the right reasons. If we use it for the wrong reasons, it's just going to die like all the other initiatives.
It probably came in for the wrong reasons, didn't it, really?
It probably did, but it has the opportunity to show itself as a value add.
Yes, and we should do more to publish best practices. As I said earlier on, the Academy of Fabulous Stuff has got a whole load of stuff on this, and I'd invite the three of you to contribute with your case studies and things that you're doing, because it's where else do people go to find out what best practice is? Folarin, you're going to have the last word.
Yeah, I mean, I just to echo what Kris and Paul have said, I don't think we can't afford for it to fall by the wayside. I think the one thing we know is that the model of care that we currently have just isn't sustainable. We'll get to the point where, and who knows when it will be, where there just won't be enough warm bodies to deliver services the way we're delivering them. So things like virtual wards, things like leveraging technology better to support care delivery that doesn't require necessarily at all times that human-to-human interface, I think are things that just have to be part of the future, and we need to accept it. We just need to be able to make sure we make it as safe and as effective as possible, I think.
Guys, it's been really interesting to talk to you, and thank you so much. I've really enjoyed it. I hope the audience have enjoyed it as well. Thank you for giving us your lunchtime. I hope we've given you food for thought back. And I'll hand back now to Jade, who I think has put some useful things in the chat box, and she's going to say one or two other things. So, gentlemen, thank you very much, and ladies and gentlemen in the audience, thank you for being part of today. And if you've given us a question, thank you for that, and thank you for being members of the IHSCM. So, Jade, over to you.
Thank you, Roy. Yes, so I've put a link in the chat box to our next special interest group meeting for the Integrated Care SIG. It's on the 14th of July, where we'll have another roundtable discussion around doing integrated care at a local city perspective versus rural. We hope you can attend. I'd just like to thank our guests today. I'd like to thank Kris Glover. I'd like to thank Folarin Majekodunmi. I hope I pronounced that right after the start. Folarin, Paul Rylance, and to our chair today, Roy Lilley. I hope you have found today's discussion really useful. If you've missed any of it, it is recorded. You can catch up, and I will send the links across that were shared in the chat in an email to you, so you can access them offline. And just like to say thank you. Enjoy the rest of your afternoon, and we look forward to seeing you again shortly. Bye.
Goodbye, everyone. Thank you.
Bye-bye.